Hello, cognitive and affective students. Uh, Here is a very brief presentation to just go over the upcoming assignment, the presentation assignment regarding integrating elements of cognition and affect with research, and primarily uh, uh, that research toward evidence-based treatments. So I want to go over some of the items associated with that uh, assignment. And in here, let's just go over these items because these items, some of them are more or less important and germane to the assignment. Some more, some less. If you can find something that is specifically germane or relevant to it, then fine. And if you can't, that's okay too. So let's look at the first part here, how the domain or domains of cognition are incorporated as agents of change, then the therapy type that should be evaluated in detail. And then in that, you want to maybe take a look at the early development, or in other words, where it came from, what some of the experiments and discoveries were relative to it, what the specific area of cognition is, how it's utilized, or in other words, is it through classical conditioning, and then in that's the case, what is the research? I mean, that is, what is the therapy attempting to alter or change, and then demonstrate examples of APA manualizations or evidence-based treatments. So look at whatever the APA manualization is, look at the method, look at the standard session count and progression, its current use, and whatever the target disorders are. Look at the mental health populations benefited. If you can find sample vignettes, please use that, or just use one or two. If you can find, and you should be able to find, outcome statistics reflecting the effectiveness of whatever the therapy is, and then use examples. And again, these include cognitive therapy via Beck or Ellis, or maybe aversive counter conditioning, and what aversive counter conditioning is effective and not effective for. Maybe systematic desensitization, covert sensitization, token economies, flooding, graduated exposure, stress inoculation training. And again, like I say here, that list is by no means exhaustive. Secondly, and perhaps not as important as this first part, is how does the theory fit the therapy? How well does the theory how is it operationalized in order to map purported cognitive constructs to the symptom change? So look at the research associated with therapist inter-rater reliability for those who are practicing and utilizing a specific evidence-based theory. Has there been any research relative to how a certain sample of therapists are in accordance or congruence with delivering that type of therapy? Is there indeed an inter-rater reliability across the therapists, even when they use the evidence-based manualized approach as prescribed by the APA, or if, let's say, that a sample of cognitive behavioral therapists say indeed we're delivering that treatment. Has any research been done in looking across a number of therapists and looking at just how reliable that procedure is in terms of their provision of it? Let's see. And here's examples for those who purport implementation of CBT or mindfulness or EMDR or covert desensitization and so on and so forth. Are those do they indeed demonstrate inter-rater reliability? And of course, one would expect that a certain amount of inter-rater reliability would be established if they're following the procedures as prescribed. So the other thing I wanted to show you is some basic examples of some of this. So see, this is this is an example of a student who looked at simple basic exposure therapy. And this by far is not the ideal best model, but I believe that the student did a reasonable job as far as the presentation is concerned. So how is the treatment, the treatments developed to help people confront fears? Psychologist utilizes exposure therapy, blah, blah, blah. And then moving on, mental health populations that benefit from the exposure therapy. And it talks about phobias and panic disorders and social anxiety disorders and these sort of things. So she hits on that. Then the origin of exposure therapies and some of the people who were responsible throughout history in discovering some of the areas uh, associated with the techniques used for exposure therapy and how it works. What are the practical applications of it based upon the theory of it and how it works and the relationship between learning and also the association between classical learning and classical conditioning and also operant conditioning. So looking at both uh, uh, how let's say a phobia or a fear becomes established via classical learning, and then how it's maintained relative to avoidance and negative reinforcement, which is part of operant conditioning. Then some notable limitations of the treatment in that a lot of professional people do not really implement exposure therapy. And if not, what are some of the reasons? Is it simply that they're not looking at the manuals and utilizing that, or they believe that perhaps they have another way of doing it that could be better? So then look at, if you have any, find a client vignette. The student did indeed find a vignette for exposure therapy. And in this, the behavioral presentation includes agitation, irritability, hostility, hypervigilance, which then leads to flashbacks, fear and severe anxiety and mistrust, a loss of interest in typical activities that he used to enjoy, and problem sleeping. And then the vignette goes into then describing how the therapy helped him. In the APA manualization, continuation of the client vignette, we want to look also for risk of suicide, so on and so forth. This is what the student presented. And again, I thought it was a reasonable presentation, perhaps a bit short, but then again, the vignette took a considerable amount of time. She probably could have gone a little further into more of the research and a little bit of the detail in outcomes. It's not here, but I just wanted to give you a little example of what I'm looking for. That you can, of course, apply a considerable amount of variation to what you do. So I don't want to prescribe an exact formula for how you do it. Just give you a very, very general template, an outline of what to do and what I'm looking for. Again, if you go back here and look at part 2, which is in here, how does the theory fit therapy, and how well is the theory operationalized in order to map purported cognitive constructs to the symptom change? So in this case, it really would be interesting to look at any therapist inner reliability for anything that's any given therapy that's done, mindfulness or EMDR or covert desensitization. How well are the therapists who are utilizing these methods, how do they rate as far as their inner rater reliabilities, or in other words, their consistencies across the provision of the specific therapy types or domains. Anyway, that's about it. Please feel free to email me if you have any other questions regarding this. But again, you can you can apply these items reasonably loosely, as long as you hit on some of the major issues, and like the ones that I just showed you. But if you go above and beyond some of these, that's even better. So at any rate, I'll conclude this and hope that this helps you. Bye.